Thank you so much, Bridget. I have chills and really appreciate you sharing your personal story and treating us to a song. I wonder if that's a first for the Academy. Now, we have an amazing panel lined up for you for this first session. I'll introduce them in order and ask them to come up and join Bridget at the table. And some speakers may choose to speak from the podium and others may speak from the table. I've kind of let it be free form, depending on comfort. First, I'd like to introduce Dr. Marshall Chin. He is a Richard Parrillo Family Professor of Healthcare Ethics in the Department of Medicine at the University of Chicago. He has extensive leadership experience, and I really can't do justice to it, but his full bio is published in the booklet, and I would really encourage you to read through it. He is going to provide a general overview of equity and access issues impacting the healthcare system in the United States. And then following Dr. Chin, Dr. Kimberly Johnson, who is an associate professor with tenure at the Department of Medicine in the Division of Geriatrics at the Center for Aging and the Center for Palliative Care at Duke, will help us understand equity and access issues as they pertain particularly to people with serious illness. And then finally, Dr. Edward and I'm sure I'm butchering that name, but Matzinger, close enough, is a professor of medicine and the director of the Women's HIV Program and the Center to Advance Trauma-Informed Care at UCSF. He is going to help us understand the role that trauma-informed care plays in the quality of care for people with serious illness. And again, there is so much more to tell you about our panelists, but please refer to their bios in the booklet. At the conclusion of their prepared remarks, and we've given each one of them 18 minutes, which is insufficient for their expertise, we'll engage with the audience in an interactive discussion and Q&A session. So please, panelists, come and join us at the table. Thank you.
Well, thanks very much, Peggy. And thank you, Bridget, for sharing your powerful story and the beautiful singing that the Seattle Seahawks made a wise choice having you do the national anthem before their Cowboys game. So we're going to start broad of this panel and then narrow down to a more focused topic. And my job is to talk about what do we know from the wider field of healthcare regarding what works to achieve health equity. And my remarks are based upon my own research doing multi-level interventions. Then over the past 14 years, I've run a couple foundation programs in equity, a Robert Wood Johnson Foundation program and a Merck Foundation program. And we've funded about 44 grantees, so we learned a lot about what they have learned from their interventions. We've done 12 systematic reviews of the health disparities intervention literature. And then we're in year 6 at the University of Chicago of an effort to try to achieve health equity at our own institution. And I'm a general internist by clinical background. So here are the 5 lessons. I'll go them quickly and then we'll do the deeper dive. First, there's no magic bullet solution. Achieving equity is a process. We need to address social determinants of health. We need to address payment and incentives. And then very importantly, and I'm glad that Peggy started the discussion, we also need to frame equity as a moral and social justice issue. And during my remarks, the frame here is that our equity goal is moving the national numbers. This is the Agency for Healthcare Research and Quality, National Healthcare Quality and Disparity Reports. So as opposed to a frame of purely improving equity in your own organization, my talk is how do we improve equity nationally so we move the national numbers. So now about 2005, this was sort of the era where we had a lot of studies, documenting disparities, quite a bit of studies on why we have disparities, and relatively few on solutions. At that point in time, I became the director of the Robert Wood Johnson Foundation, one of their equity programs. And I had to admit that I had this sort of naive belief that, that we'd find magic bullets, that we would fund grantees, some would be successful, some would not succeed, and we would disseminate, scale up, and spread those interventions that worked. It didn't take me long to realize that that was not going to work. And the major reason why is that context matters. That you might have a wonderful program for African Americans in Birmingham, Alabama, but that may or may not work for African Americans in the South Side of Chicago. Or if you think about like different healthcare organizations, the political and financial contexts differ. So for example, if you're in Seattle, or you're in Chicago, or you're here in DC, the relative mix of fee-for-service payment and managed care differs. And so the incentives and the actions of organizations will differ also. Or history. You might have like two clinics that are in the exact same place now in terms of their staffing, their patient populations, their leadership. But if the history of how they got to where they are now differ, it's going to make a difference. And the type of interventions that may work could very well be different because of that history and what's acceptable and the dynamics there. So you need to work through your own solutions. Now, having said that, there is value in having a menu of evidence-based solutions, that organizations, they like to have a menu that they at least have as a starting point to think about tailoring and to spur ideas, but everything has to be individualized and tailored. The sobering thing is that when you do look at the literature, there aren't a lot of common themes about what works to reduce disparities. We reviewed over 400 healthcare disparity intervention papers. The best we could come up with were these 6 different themes. Multifactorial interventions that attack the different levers or drivers of disparities, culturally tailored quality improvement approaches better than generic, team-based care, a lot of great evidence for nurse-led team-based care, not surprisingly involving families and community partners, community health workers. So part of Bridget's intervention was sort of a community health worker, lay health worker, patient navigator, promotor type model, robust literature. And then interactive skills-based training as opposed to more passive didactic lecturing, more effective in terms of patient teaching and education. So here's a variant of the model that Darcy showed. And you might think about Bridget's story of the targets for intervention, because there were a lot of targets for intervention in her story. Left-hand bubble, you have Bridget as a person living in her community. And there are all the issues she mentioned in terms of the community's knowledge or lack of awareness about some of the breast cancer issues. If she has access to care, she goes to the right-hand bubble, becoming a patient, interacting with a clinician, and there were a lot of clinician communication issues in her story. Within a healthcare organization, a lot of systems issues, for example, the follow-up of tests in one of her hospitals. And then above that, the policy superstructure, the big one being financing. Money's a big driver. At the very bottom, impacting process of care and outcomes. So achieving equity is a process. So there are these 6 different steps. I'll go over them more quickly, and then do a deeper dive into a few of them. So first is creating a culture of equity. So I think a lot of health organizations, they do cultural competency training. They may also stratify their clinical performance measures by a factor such as race. So that's a start, but only a start. Culture is critical. This is a very famous phrase from the business world that culture eats strategy for breakfast. The point being that you could have wonderful interventions, wonderful tactics, wonderful strategies, but if equity isn't part of the culture of your organization, in other words, if people don't really care about equity, or you're not going to get very far. And so I think a lot of times at workshops and roundtables, we spend a lot of time talking about technical things and technical solutions. But again, back to, I think it was it was Peggy talked about this issue of equity as a moral issue. We have to really sort of create that culture of equity. Otherwise, all these sort of expertise and technical things just don't matter. The second and third bullets have to do with making equity an integral part of quality. And actually, Darcy showed the 2001 IOM slide of the 6 domains of quality. 2010, the IOM updated the model. So as opposed to being one of the 6 domains of quality, equity is now a cross-cutting dimension that cuts across each of those other dimensions of quality. So in other words, equity is baked into all aspects of quality. So in some ways, it raises the importance of equity beyond being one of, but in the past, the poor, sick stepchild with inequity. Fourth is designing interventions. And Darcy also used this phrase of the equity lens. There's just too many different organizations that basically have a rising tide fits all, or lifts all boats type of philosophy that if you do some type of generic approach, well, it's going to improve care for everyone. But the key is that you have to tailor to the specific situations and drivers of disparities, and sometimes the generic approach doesn't work or can even worsen disparities. Fifth is implementation, talk more about that. Sixth, sustainability, again, I'll talk more about that. I'll make a couple more points about quality improvement. So you need to do a root cause analysis where you look at the drivers of disparities. One of the most common errors that we've seen people do is that they don't talk and discuss with the community and the people affected by the disparities. And oftentimes what they'll do is they'll do a proxy. So for example, if they see a breast cancer disparity issue, they may say, oh, if we talk to our African-American doctors and nurses and social workers, well, they'll know what to do because they're African-American. Maybe they have more insight than me, maybe they don't. But certainly they may have blind spots as opposed to the actual patients, because they may have a different lived experience than the patients that have been affected by disparities in the community. There's the need to iteratively address the specific barriers and facilitate the change. In other words, we never get it right the first time. The disparities is a complicated issue. So we need to try something, learn from that, fix it, try again, and it's an iterative approach. It's very rare to be able to get something right on the first time. So implementation, there's this whole field of implementation science, which is the science of how to get things to work in the real world. There are a lot of different models. They're all about the same. This is the VA's model by Laura Damschroeder from the Ann Arbor VA. She talks about 5 different domains. First, why is your intervention better than the status quo? What are the external incentives, such as the payer environment, the financial incentives? What's the culture of the organizations that you're working with? What are the beliefs of the individuals whose behavior you're trying to change? What's the process then of change in terms of planning, executing, and evaluating? And each of these different domains has another half dozen subdomains. But in some ways, it shows things in the complexity. This need to tailor because this in Bridget's story, or we went through some of these different contextual matters. There's a lot of different factors that have to be taken into account. Otherwise, it's kind of wishful thinking that a generic intervention is going to work. So addressing social determinants of health, this is perhaps maybe the hottest issue right now in health disparities. I just want to make 2 points about this. I think most health organizations are doing the first bullet, if they are, which is looking at individual patients and trying to identify their individual needs. So they'll screen for social needs like housing or food insecurity. They'll try to refer to relevant local community-based organizations and develop some type of information loop so they get information back from that community-based organization. So you've heard about population health management, and this focused upon the most costly high utilizers. So that's really sort of the incentive and the interest of the healthcare organizations just globally. What there's much less of is the second bullet, which is addressing the underlying structural barriers. So especially structural racism, the reasons why, for example, we have segregated housing, we have such income inequality, the differences in the education system, these very strong, powerful drivers that, in fact, explain much more about disparities than health care. So there's a need to have free, frank, fearless discussions about structural racism, colonialism, social privilege, and then to engage into sectoral partnerships. A couple of years ago, I spent a summer in Aotearoa, New Zealand, trying to compare what New Zealand and the U.S. were doing for health equity. And these are my collaborators. And one of the great joys were the amazing collaborators. And the 3 people on the left, they're Maori, the indigenous peoples of New Zealand. And we engaged in a lot of these frank, fearless, honest discussions about colonialism in particular, that I learned a lot about colonialism. And it convinced me that we're not going to really get there in terms of equity, either within an individual organization or as a country, unless we have these difficult discussions. And these discussions are difficult for a variety of reasons, but one I would point out is that power is the issue, ultimately, when it comes down to it. Control over resources, control over the historical narrative. So it's interesting. There's just control over what objectively has happened in the past. And then today, control over the framing of the health disparity issue. So for example, is it an issue of individual responsibility or the structural drivers of inequity? So again, the frame is critical. This is Drew Weston, who's a psychologist at Emory. He wrote this book called The Political Brain. He basically argues that the Republicans are much more effective than the Democrats in terms of political messaging. And to simplify his argument, he says that the Democrats appeal to the head and Republicans appeal to the heart. What's more effective for messaging and communication? The heart. So, for example, he'll say something like, you could say, well, there's the underemployed Or there's that hard-working mom working 2 or 3 jobs just to put food on the table for her kids. Or ACA, well, you could say, well, there's an individual mandate forcing people to buy health insurance, or you could say, well, it's a tax on freeloaders in the system, Or, I'm from Chicago, we just had the election, and so historical election, Lori Lightfoot, lesbian African-American woman, defeated Toni Preckwinkle, African-American woman. Probably a variety of reasons for that difference, but one of the reasons probably is that Toni Preckwinkle, she's the Cook County Board President, advocated for a soda tax in terms of the obesity epidemic. Didn't pass and caused political damage. Why didn't it pass in Chicago? Why did it pass a soda tax in Philadelphia? The messaging. Intersectoral partnerships, so crossing health and non-health care. One of our Merck Foundation grantees is La Clinica here in Washington, D.C. They have a wonderful collaboration with a legal services group about a block away from where they are to do medical legal services for the primarily El Salvadoran migrant population. So addressing payment and incentives, this is, I think, this and the social determinants are, I think, the 2 frontier areas in health disparities. So you need to have a business case to achieve equity, whether you're an academic behemoth like the University of Chicago or a fairly qualified health center on the south side of Chicago. There's this huge policy gap. We will have this wonderful rhetoric about how our nation values health equity. For example, the Healthy People 2020 statements, some very nice health equity language. But then you look at the actual policies our country has, there's relatively little there about specific policies that support and incentivize health equity. So you can think about 3 policy goals. 1, explicitly designing your quality of care and payment policies to achieve equity, holding the healthcare system accountable through public monitoring and evaluation, and then supporting with adequate resources. So the National Quality Forum, they had this recent report, I guess a year or so ago, the 4 I's for health equity. I'm going to focus on the last I, incentivize the reduction of health disparities and achievement of health equity. So they had 10 recommendations on this, and I'll just share 3 of them with you. So accountability, we talked about stratifying your clinical performance measures by factors such as race, ethnicity, socioeconomic status, disability status, serious illness. Redesigning payment models to support health equity. So you can think about it, there's a fair amount of health equity infrastructure, some like community health workers, like Bridges program, would traditionally not be funded by a current fee-for-service system. So how do you ensure that money from global payments, from capitation, money from that flows towards this type of health equity infrastructure? If your goal is improving a specific process like mammography screening for African-American women, there may be a role for specific pay performance, for pay for rewarding that. How do we then finance the integration of health and social services? And then there's a need to tailor to the safety net. And Alice, I think we'll probably talk about this a little bit later today in terms of tailoring the quality improvement and the money to the safety net. So the newest iteration of our Robert Johnson Foundation program is called Advancing Health Equity, Leading Care, Payment, and System Transformation. We're working with 3 major stakeholders: state Medicaid agencies, Medicaid management organizations, frontline health organizations. The point being that all 3 have to align to achieve health equity. No one group can do it alone. So I'm going to end backing and harking to Peggy's point about framing equity as a moral and social justice issue, and this whole issue about creating a culture of equity. Very famous quote from Dr. Martin Luther King, 1966. Of all the forms of inequality, injustice in health is the most shocking and the most inhuman. The argument being that if you're trying to have other forms of human attainment, whether it's well-being, employment, education, unless you had your basic health, you wouldn't be able to get there. The other theme to think about is from ethics, the field of distributive justice. The greatest American justice philosopher of the 20th century was a man named John Rawls, who was a professor at Harvard. He had this concept of a veil of ignorance, and what he thought was that if you were trying to come up with the laws of a just society, the fairest laws would have been created before you knew your lot in life, when you were behind the veil of ignorance. Before you knew whether you'd be African American, Latino, white, Native American, or Asian American. Before you knew whether you'd be rich or poor, healthy, not healthy, educated or not. If you create the rules at that point in time, you'd have a fair system, because once you know your lot in life, explicitly or implicitly, this is the self-interest you try to protect. So the New Zealand paper, we have a simple conceptual framework. The middle part is the healthcare system. You see the 3 big words on the outside: culture, history, and values. Again, that point about those really drive everything else. So For Merck Foundation program, we went on the site visit. We have like 8 grantees, and we have this wonderful grantee who is in Frontier, Idaho, St. Mary's, Clearwater Valley. And when we went on the site visit, I noticed that they had 2 badges. They had their ID badge, the main ID badge, and they had then a second badge. It turns out that for all their employees, new employees, they have them do a half-day retreat where each comes up with their own personal mission statement. This is the one of their chief medical officer, a wonderful man named Dr. Kelly McGrath. He called his Health and Harmony. With compassion, gratitude, integrity, and joy, I guide myself and others to treasure the beauty and goodness in our world and to discover and achieve the unique ways in which we are called to make it even better. So from the field of motivation, I mean, the most powerful motivator is our intrinsic motivation. Extrinsic motivators like money, they make a difference, but there's only so many things you can motivate with money. And so ultimately, it really comes down to, again, professionalism, your sense of values, and equity, and this is getting the points to creating a culture of equity. So especially for this audience, I want to share this quote that you may be saying that, well, you're Pollyannish, Marshall, in terms of all this appeal to the morals and to justice and all. We have a very sort of divided, partisan country, and we're never going to get people to agree on sort of equity. Well, I took this conflict resolution course by Dr. Jennifer Smith, who's a general internist, a geriatrician, and a palliative care doctor at Cook County Hospital for many years. And so as you can imagine, she had to deal with a lot of very difficult conversations. And in this essay, I shared the story that Dr. Smith explained that a conflict is a personal narrative with a beginning, middle, and end. At the beginning, parties frequently experience powerful emotions such as anger, frustration, fear, and surprise, and often make assumptions based on their values and biases. The middle phase encompasses listening and telling, adjusting facts, and clarifying options. In the end, one can hope for agreement, compromise, and reconciliation, but at a minimum, it should be possible to envision a new future with common facts, decreased emotion, and more clarity moving forward. I'll end with one more story that, again, on this Idaho site visit, it was in the middle of the election in the fall. And so this is 2 of the signs we saw. Janice McGeachin was a candidate for lieutenant governor. And as you know, Idaho is a conservative state. So keep Idaho conservative, love America, love Idaho. She won her election. There also was a referendum ballot question 2, which was expanding the ACA. That passed by a 2-to-1 margin, and one of the major proponents fighting for it was a conservative member, a Republican in the Idaho House. I'll end with this quote that for all of us, leadership matters. It is our professional responsibility as clinicians, administrators, and policymakers to improve the way we deliver care to diverse patients. We can do better. Thank you very much.